I'd like people to stop telling women there's nothing that they can do for their symptoms, because there are things they can do. Even if they can't take menopausal hormone therapy, there are still treatments that they can have.
Welcome to Thriving in Menopause, brought to you by Prevention Magazine. I'm Zoe Mernier, the editor of Prevention. Thank you for joining me for episode 6 of season 12. Today on the podcast, we're going to be looking at a very specific experience of menopause, and that is of medically induced menopause, which can bring about a set of very complex and challenging issues at a time when a woman is typically already going through a major health crisis. To guide us through some of these, we're honoured to be joined today by Professor Martha Hickey, Professor of Obstetrics and Gynaecology at the University of Melbourne and Adjunct Professor of Obstetrics, Gynaecology and Reproductive Sciences at Yale University. She is now leading a world-first study, What Happens After Menopause. Professor Hickey, thanks so much for joining us today.
Hi.
Okay, so maybe you could just start by explaining exactly what medically induced menopause is.
Well, menopause is a normal event that happens to all of those born with functioning ovaries, but about 5% of women go through menopause that's induced by medical therapy, and that would either mean chemotherapy or radiation treatment, or surgically, meaning removal of both the ovaries prior to natural menopause.
Right. So in what clinical situations is medically induced menopause typically actually recommended?
The most common for the chemotherapy or the radiation-induced menopause would be cancer treatment. And the most common kind of cancers that would happen in young women would be cervical cancer.
Right.
Also, with breast cancer, which does affect young women as well, sometimes their ovaries are removed as part of their treatment if they have an estrogen-sensitive cancer. And for those having ovaries removed to reduce their risk of ovarian cancer, that's another big group. Those would be women who are at high risk of ovarian cancer because they've inherited a gene.
Of course, yes. So how does that sudden hormonal shift of induced menopause affect the body and mind, I guess, compared to a gradual natural transition?
We've been looking at that in the setting of surgical menopause, where there's a very sudden change in the hormones that your body's exposed to. And we've found surprisingly little. We've followed women up for 2 years, and we've got a control group who retain their ovaries and just remain premenopausal. And in particular, the symptoms that women had when they had their ovaries removed were quite common, but much milder than we expected. It's often said that surgical menopause causes severe symptoms, but nobody had ever looked before in a prospective trial, and we actually didn't find that.
Oh, well, that's very interesting. Yes, that goes beyond everything that I've heard about what the experience is, that it's usually,
Well, that's right, and it just shows the importance of doing proper trials in the area.
yes.
So cross-sectional studies, which are nearly all the studies that are published, where they go to women and say, you've had surgical menopause, how do you feel? They report very severe symptoms, but what we've done is actually followed women up from before the operation until afterwards, and it's quite a different picture.
Right. Did you find that symptoms typically last longer with medically induced menopause, or is it a very individual thing like normal menopause is?
Yeah, I mean, in normal menopause, symptoms last something between 4 to 7 years, but not always at the same severity. And they're worse usually in the year around the final menstrual period, so in the year around the menopause itself. We've only got 2 year data from our WHAM cohort, who are the surgical menopause cohort, and we found the symptoms are worse by 3 months, but they don't get worse again after that.
Okay, well, that is certainly reassuring for women, set to experience this. I also did find it interesting to discover, or I read, that older women with cancer may actually experience menopausal symptoms all over again if they've gone through a medically induced situation, even though they've already experienced menopause. Is that correct? And do you know why that would happen?
Yes, so women who've already experienced menopause, say they get breast cancer that's estrogen sensitive, which is what most breast cancers are, then they're usually advised to take what's called endocrine therapy, which is an estrogen blocker. and that so 5 years or sometimes up to 10 years, and that will commonly induce hot flushes again.
Right. So obviously surgically induced menopause is always a permanent situation, but are there sort of instances of medically induced menopause that are reversed?
Yeah, yes, it's an interesting question, and when if you not if they're surgical, that's as you say, that's it, they're gone. Radiation is normally always permanent as well.
Right.
With chemotherapy, there are some women who perhaps if they're very young, maybe 18 to 25, when they have the chemotherapy, they have enough what's called ovarian reserve, so enough eggs stored that even despite that damage, they might still have some recovery later on.
Okay.
But we don't have any way of predicting that at the moment.
Yeah, fair enough. Is that something that you're looking that research is being done in that area, or?
Yes, I think so. There's some research that's been done about a blood test, which might help to say this is never going to happen. But there's no research I'm aware of to be able to say, well, you might be somebody whose ovaries might start working again.
Yeah. Um, so what are some of the implications and impacts then of medically induced menopause, both in the short and the long term?
In the short term, it really depends on your age. So if you're 40 or above, it medically induced menopause may not have much impact on your long-term health. In the short term, you may experience symptoms, and again, that can be troublesome. And for women who can't take estrogen treatments, then we do a lot of work around non-hormonal treatments for their symptoms. For those who are younger than 40, then there are issues around bone health and perhaps heart health in the longer term that do need attention. And again, in my practice, where I see a lot of young women who've had cancer, we try to be very clear about making sure that those who are eligible to take menopausal hormone therapy actually do get access to it, because that can treat symptoms and also help prevent fracture.
Yes, and so for those that can't go through that, what are some of the non-hormonal treatments that you might give those women?
Yeah, there are quite a few. We've recently looked to try and understand what works best, and that's in press at the moment. But there are drugs in Australia. We do have quite a big range of things. So I do often hear from women, cancer patients, that they've been told there's nothing that they can take, and that really is not the case. There are things that they can take that they may not be as effective as estrogen, but they're pretty effective.
Okay, that's reassuring as well.
Hot flushes? No sweat. Try Promensal Menopause products to relieve common menopausal symptoms for both perimenopausal and postmenopausal women. Promensal understands that hot flushes and night sweats are not the only things going on in your life. This is why Promensal has added 2 new products to their range. New Promensal Libido and Energy, because face it, we all could do with a boost of both. And new Promensal Brain Fog to help increase short-term memory, mental recall, and reduce cognitive fatigue. Now, where did I put my keys? Promensal provides premium holistic supplement care for women using evidence-based ingredients for products you can trust. Promensal is here to help you take control of your own health and live your best life. Plus, check out our brand new look in-store now. Always read the label and follow directions for use.
Are there specific risks to cognitive health? Is that a risk factor?
Yeah, it's a much harder one. I mean, whether or not estrogen and menopause are linked to cognitive health is uncertain, basically. There are short-term cognitive issues, sometimes referred to as brain fog, that many women report as they go through menopause in cross-sectional studies. We don't have any longitudinal studies. But we have no idea whether or not that experience of brain fog is linked to some later cognitive problem like dementia.
Yeah, because there has been sort of talk of declining estrogen having a bit of an effect on the risk of dementia. Is that
Yeah,
the
there's
case?
been a lot of talk about that, and I'm also involved in research around that area with a group at Harvard. But just to say, going back to WHAM, our prospective cohort of surgical menopause, at 2 years after they had their surgical menopause, we didn't find any changes in their cognition.
Okay.
Well, at 1 year and at 2 years. And there was a tiny effect of taking menopausal hormone therapy, and a tiny positive effect. So we were really surprised. I ran this study with one of the leading menopause cognition researchers in the world. We were expecting to find big changes in cognition. We didn't find anything.
But then maybe in younger women, is there a risk that if they have got that loss of estrogen for a longer period, that they could be more at risk of perhaps getting dementia
that's
a
right.
bit
They
younger?
could be. So we're planning to look again at 10 years.
Yep, for sure. Okay, so from a different perspective, how have you found in your experience that medically induced menopause can impact identity and relationships and mental health?
I think for young women who have experienced cancer, which is what nearly all these women have experienced, or who find themselves carrying a gene that markedly increases their risk of cancer, that those things are very difficult experiences and may make you feel very different from your peers and fearful. And of course, for those with a family history, they will have seen close members of their family die of these cancers. That's the usual sort of pattern. So I don't think I'd assume to pick menopause apart, particularly from those other complexities.
Yeah.
It's particularly difficult, though, for women who want to have children and have not yet had any children, to be diagnosed with a cancer that's going to make having a child very difficult or impossible.
Absolutely. Absolutely. Is there any sort of suggestion or that you can offer that ways that women might be able to prepare emotionally and or physically if they're about to undergo a medically induced menopause?
Yes, it depends on the cancer that they have. So for some cancers, breast, for example, it might be possible to have some kind of what's called fertility preservation, which is a way of trying to stimulate the ovaries and collect eggs, generally, and freeze them so that she could access them in the future should she wish. Because her uterus will still be functioning, but her ovaries probably won't in the future.
Yeah.
So that's a straightforward situation, more straightforward situation than, for example, somebody with cervical cancer who might have a lot of radiation to their cervix, including their uterus, which makes implanting a pregnancy and carrying a baby impossible in most cases. So she could have their eggs frozen, but she'd be looking for a surrogate down the line.
Yep.
And then the other situation that I suppose I see quite a lot would be somebody with a hematological cancer, like a leukemia or a lymphoma. They could potentially have their eggs frozen, but their treatment's got to start like tomorrow, because it's a very serious condition. And we don't at the moment have any way of guaranteeing that those eggs don't contain the cancer cells. So if they're taken out and put in the freezer and then put back at a later time, that could potentially reintroduce the cancer. So it's fortunately, we have excellent services talking to women at these times about what their options are, but there's no kind of cookie cutter answer for cancer, unfortunately.
No. And I guess would there also be situations where stimulating egg production wouldn't be advised as well?
They've kind of worked that out, really. They can stimulate the ovaries to produce eggs. What you need, though, is the time that takes to do it in. It needs sort of 10 days.
Yeah.
And some cancers, as I said, the leukemias particularly, you don't really have 10 days.
Struggling with thinning hair or lack of volume? You're not alone. New Nordic's hair volume supplement is formulated with herbal ingredients like zinc and biotin to support thicker, healthier hair. Plus, it nourishes your nails and skin for a complete beauty boost. Discover the benefits at hairvolume.au and give your hair the support it needs naturally.
You're leading a world-first international study called What Happens After Menopause. Can you tell us about that and what you're finding in that study, or what stage the study is at?
Yes, thank you. So that was a study I established in 2016, which was to try and understand what happens really to women who have their ovaries removed prior to natural menopause. It's called surgical menopause, because I could find no prospective data on this subject, but a lot of people saying things like it causes terrible symptoms, it does this, that, and the other. So I recruited 100 women having surgical menopause, 100 controls, and they've been followed up very closely for 2 years. And we've looked at mental health and symptoms, obviously, menopausal symptoms. We've looked at sleep, we've looked at cognition, we've looked at heart health, metabolic health, bone health, sexual function, other things. So it's been very informative to answer the question, what happens after surgical menopause. But we've only followed them up to 2 years, and 2 years might be too early to see some of the changes that it may happen. So we're hoping to do another 10-year follow-up now to get more information.
And I mean, apart from the fact that things like the symptoms weren't as strong as you discovered, were there any real revelations from what you've come across so far?
I think the main revelation was that the menopausal hormone therapy helped, but it didn't return the woman's situation to how she was before she had her ovaries out.
Yep.
And I've spoken with a few. There are other studies around the world, that are looking at this, not quite in the same way as us. But they've all found the same thing. You can have your ovaries out because you need to, because you've got a high ovarian cancer risk, for example, and you can take the hormones, but it won't be the same.
Well, that's, I guess, something that is continuing to be worked on. I mean, are there any additional developments in research around medically induced menopause that are sort of new and evolving?
I think the big new a couple of things really. The cognition work, I think, is really taking off. So I think a lot of people are very interested in the difference between when you do tests of women's thinking, cognition, memory, whatever, they're all normal. But women are saying, I don't feel right, my memory's affected, I've got a brain fog. And we need to try and bridge this gap, understand what's actually happening in that space.
Absolutely. Are there any other big changes that you'd like to see in how the medical system approaches treatment, follow-up, or education around medically induced menopause?
Yes, I'd like people to stop telling women there's nothing that they can do for their symptoms, because there are things they can do. Even if they can't take menopausal hormone therapy, there are still treatments that they can have. And it's disappointing to hear that so often. And I think the onus is on us really to get this information out to as many people as possible, so that they know what options are available.
Yeah, I mean, it's so tricky, isn't it? Because they're experiencing cancer, so they're going through this serious health crisis, and so a lot of people, I guess, see the whole menopause side of it as secondary, but sometimes those symptoms are just adding to the misery that they're going through. So it's something that needs to be almost looked at in tandem and looked at as important as treating, say, the symptoms of their cancer treatment or whatever. Yeah,
that's absolutely right, and they're also interrelated. So we've shown, for example, that women who get their symptoms treated, with breast cancer, who get their menopause symptoms treated, are more likely to stay on their cancer treatment.
Right.
So that actually has got implications for their survival after breast cancer.
Wow, that's significant. Well, look, unfortunately, that's all we have time for today. But thank you so much, Martha, for sharing your valuable insights with us. It's been great.
Nice to meet you.
And listeners, thank you for joining us as well. If you liked this episode, we'd love you to rate, review, and subscribe. Meanwhile, for more information about living your best life at midlife, pick up a copy of Prevention magazine. I'm Zoe Mernier. See you next time.